Top Med Talk.
This is Top Med Talk, the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. The EBPOM World Congress is taking place this year between the 7th and the 9th of July at the British Library in London. Check out ebpom.org now.
Welcome to Top Med Talk. I'm Andy Cumpstey and I'm here in Marrakesh in Morocco at the World Congress of Anaesthesiologists. It's a huge event. As we've said before, we've got over 4,000 people from over 130 countries with us. It's a fantastic place, a really good buzz around the conference hall. I guess one of the highlights of this week are the World Federation of the Society of Anaesthesiologists Awards. And one of those awards is for innovation. And I'm really delighted that we've got the winners of this year's award here to come and speak to us on Top Med Talk.
Yeah, my name is Vijay. I am a pediatric surgeon. For about 30 years, my wife Anand, who is here with me, and me worked in a remote rural hospital in Assam. And that is where we had the idea of developing this device.
Fantastic.
I'm Miriam. I'm an anesthesiologist. Vijay and I had been working in this part of Assam, which is wedged between Bangladesh in the west and Burma in the east. And it is in a very needy area. We chose to work in this place because there was no adequate surgical facilities and many women were dying those days. Assam is flood prone, and once the roads are flooded, it's very difficult for them to go to the nearest surgical center for cesarean to be done. And that is when my husband and I decided to join this place.
So when we went there in 1992, the hospital was closed for the previous 10 years.
Right.
But previous to that, it was a leprosy hospital with about 60 leprosy patients. And there was an American surgeon who had worked there for about 25 years. So it was on a 1,000-acre forested campus and surrounded by a very thickly populated area. When we left from the hospital about 30 years later, it was a 200-bedded hospital. And we were doing about 7,000 deliveries a year.
Wow.
And about 8,000 major surgeries and about 150,000 outpatients. We had started a nursing school, biodiversity research projects, and branch hospital in a nearby state. And today, 5 years after we left the hospital, it is even busier. I think 2 months back, they had 850 deliveries in a month. We did a lot of research on sustainable, high-quality treatment focused on the poor people. And that was studied by the Wharton School of Business, and it was published. It was called as the Makunda model.
And how did the idea for this device come to being?
So when we worked there, we did not have a blood bank. The nearest blood bank was 50 kilometers away, and it took 2 hours to reach there. So when we had a patient who required blood, at that time the Indian government allowed hospitals to purchase empty blood bottles. So we would bleed at one of the relatives.
Right.
For the blood. But for ruptured ectopics, we had the blood inside the patient's abdomen. And we could scoop it out, filter it through many layers of gauze, and then inject it into a blood bottle and transfuse it back into the patient.
Wow.
So since it is the patient's own blood, there is no need for a cross-match or infectious disease screening, and the blood could be transfused on the operation table itself. And we probably did about 100 of those. But this is an extremely cumbersome method because you need to manually scoop out the blood. So I had this idea of a device which would do all that.
All that for you. Yeah.
Yeah, with a closed system of tubes and filters so that there is no need to have additional manpower.
So I think you said 7,000 deliveries a year with no blood on site. So if any blood products are hours away, essentially, would you be able to request blood in advance, or is this always a reactive needs-must type intervention procedure?
Actually, the Indian government rules and regulations for having a blood bank is very difficult.
Right.
And in a remote area, the number of qualified pathologists are also not there. So what happened was, for many years, we had been going to the government of Assam, running from pillar to post, asking us to sanction a blood bank. But finally, they agreed to give us a blood storage center, where the mother blood bank is 50 kilometers away. And what we used to do is we used to collect blood during voluntary blood donation camps. And they would take it and keep it in the mother blood bank and give it to us where needed. So that really helped us a lot.
We could keep about 10 units at a time.
Yeah, so we
Right.
could, yeah, yes.
And then, so you mentioned you did about 100 of these cases where you were manually auto-transfusing. Over what sort of time periods are we talking? Is that 100 over a few years or 100 over a decade or?
Most of this was in the early 1990s.
Yeah.
When it was still legal to for hospitals without a blood bank license to purchase blood bottles.
Right.
Towards the end of the 1990s, the government made it a criminal offense
Oh, wow.
to have a empty blood bottle in your hospital if you didn't have a blood bank. That made it very difficult to treat patients who needed blood, and most hospitals simply referred them away. And there are many people who died on the way to the nearest blood bank. And when they reached there, they would say, we don't have your group, and refer them further for another many hours. So if we have this type of blood available, clean blood in one of the body cavities, we can avoid all that. So that was the motivation to develop this device.
And the problem is, if you have to do this scoop ladle technique, and human resources are the least available rurally. So if you say it's myself as an anesthesiologist, my husband as surgeon, a scrub nurse and a floor nurse. So with only few of us to do this was very difficult, and I at times found it very difficult to leave the patient to someone else to go and do this and then transfuse the blood. So that's when we thought something like this will help us to take the blood as early as possible and give it back. And it can be done with the least number of people around. And there won't be any transmission of infectious diseases to the healthcare provider also, because there is no touch techniques. Yeah.
So you had this remarkably insightful vision of where you wanted to get to with this
Yes.
new piece of equipment. What's the journey to go from doing it manually in 100 cases to winning this innovation award? How does that progress?
Actually, I was quite interested in engineering. I had joined an engineering college before joining medicine, but I didn't do the course. So I became involved with many hackathons. So there was one in Uganda by the Hack Camtech. I was also involved in the Indian Institute of Technology. So I pitched this idea to many places. So at one of those meetings, there was a person, Dr. Joseph Tarian. He had done his MBBS medicine and then also engineering. He was interested in this idea, and he had joined a university in Kerala called the Digital University Kerala. He pitched the idea to his department, and they obtained some funding from the government of Kerala, and they decided to take it up as a project to develop into a prototype. So my original schematic was converted into a prototype, but then we encountered a lot of problems with flow rate, with the air getting trapped. So many iterations of the device were made.
So I'm really keen to talk to those problems in a second, but just before we get to the problems, can you maybe, and we can put in our show notes some links to the documents you send me with the background of this device, but could you maybe just talk through at this stage in your head what the schematic looked like and what you were trying to come up with and trying to build, and then we can talk through the problems you went through on the way?
So the device had an inlet tube, which is similar to the abdominal drain tube.
Yeah.
That is held in the hand of the surgeon and put into pools of liquid blood. So there are clots and blood in different pools. So we scoop out the clots and keep it into the pools of liquid blood. And then there is
in the patient's abdomen.
After opening. And then there is a device that initiates flow using a siphon effect. So I initially thought of a bellows-like device, but that was modified into something like the bulb in a sphygmomanometer.
Yeah.
So when you release it, that initiates the flow of blood. But when you pull the tube out of the pool of blood, it again stops. So each time you need to reinitiate. So when we first started working on the device, we found that along with blood, a lot of air also went into the bag. And there is a filter below, which is made of the same material that is used in blood giving sets. 70 nanometer blood filter. Several modifications were made to get to where we are now. And to get over this problem of the government not allowing empty blood bags, we made special blood bags, which cannot be used to collect blood from the vein of a donor. They can only be connected to this device.
Oh, right.
By changing the type of connector. This was tested using fluid that resembles blood by adjusting like glycerin into the correct specific gravity and viscosity. But then we wanted to test it on human blood. So we studied then at the Christian Medical College, Vellore, where we used expired banked blood to study the flow characteristics. So we were able to collect 1 unit of blood in 85 seconds.
Wow.
And 2 units, including time to take out the tube and reinitiate flow, in 3.5 minutes. So that is quite fast. It doesn't require additional manpower. It does not use any other energy. And we estimated that the cost of one device would be about $12.
So that's 1 to 12 US dollars. Yes. I mean, I've got to be honest, there's very few pieces of equipment in the UK that I can buy for 12 US dollars that are medical grade equipment. So the fact you can make this entire system for that price, I find remarkable.
Yeah. So then this university, along with the funding agency, applied for a patent in India. So it is now patented, and I am listed as one of the co-inventors. There are 3 other engineers who had worked on it. So then we were introduced by Dr. Joy Marmot, who is in CMC Vellore, to the Blood Desert Coalition in USA, based in Harvard. So I gave a presentation to them. That was included along with other innovations in an article published in Lancet. And then we were looking for industrial partner to manufacture the device. Meanwhile, I applied to a group on global surgical innovations. And last year, we won the first prize for global surgical innovations in a conference at Blantyre in Malawi. So the greatest need for a device like this would be in Africa. So we got a company in Africa, in South Africa, who manufacture similar devices. And we signed a non-disclosure agreement with them, transferred technology. But then they were not very keen on it. So that has recently stopped. So we are at present looking for an industrial partner. The Indian government has started many schemes to help innovators in medical biotechnology. So one of them is in Andhra Pradesh. So about a month ago, we went and visited them, and they appear to be interested. There are companies who are willing to manufacture it. So if you give them an order, they'll make 1,000 pieces, but they will not sell it and assume risks, get it through regulatory approval.
Right.
So that is the current status of the device.
So is it in use anywhere at the moment, or is it still an experimental prototype that needs further testing?
Yeah, it is a prototype on which the flow characteristics have been tested.
Right.
But it is not made of medical grade material.
Right.
It is made of commercial PVC tape film. So it needs to be converted into a medical grade device. There are 3 types of regulatory approvals needed. And this one comes to the highest level because we are putting tissue back into the patient. So it will have to pass through that approval process in India before it can be sold in the market. One of the barriers is that the indications for use of such a device would be like ruptured tubal pregnancy would be the commonest, and then splenic injuries, and maybe clean hemothorax. But these are not very common conditions. So for a manufacturer, They are looking at volumes to make profit. But it would be completely life-saving in many of the poorer countries where access to blood is not there.
And are there any challenges or problems in using it? I've not worked in India, I only work in the UK. We have, if you like, a cell salvage system, which would sort of be the same type of system, I guess. But I mean, one of those machines is tens of thousands of pounds, and the consumables that you have to replace for each patient are hundreds of, if not thousands of pounds. And we have problems with those expensive machines. They stop working, they need minimum volumes to achieve enough to concentrate to transfuse, they need reasonably high amounts of skill to operate. So there's challenges even in a relatively well-resourced country with a relatively expensive piece of equipment. Does this device have similar challenges?
So there are two types of device that address this problem. The first is the cell saver type of device, which washes the blood, and it's only the cells that are concentrated. That has gone through many tests. It is available in most of the high-income countries. There is a possibility of cell damage because of mechanical forces on the cells. The other device is a device called the hemofuse, which is a very large syringe with a three-way attached. So you basically suck blood in, and then when you push it out through a three-way, it goes into the collecting system. But the problem with that is it is about $120 for one piece. And every time you suck, clots obstruct the tip. So you have to flush it back out. And it needs at least one extra person because it's a heavy syringe. And unfortunately, in the past year, the company that manufactures it has become bankrupt. So for all these reasons, it's never got a wide adoption. So when we went to Malawi, we went to many rural hospitals and asked them, would they be interested in a device like this? We were told that for many years, they used auto-transfusion. So what they did is to have a large funnel, and somebody would rapidly pour the blood into the funnel, and they would collect it at the bottom with the filter. But they had to stop it because the HIV prevalence in the general population is about 10%. So there is a risk of transmission to a healthcare worker. So that is sort of avoided with this device because it's a completely closed system. So they were saying that if you could provide it for about $10 or $12, we would use it.
The pair of you have clearly used this in practice. So how, setting it up in theatre, the surgeon starts the process by putting or is the anaesthesiologist that starts the process?
No, the surgeon will scoop the blood and give it to me.
Yes.
I was there and with one more person. So we'll already keep 8 layers of gauze and be ready with small balls. So we'll filter it and suck it in a syringe, 20cc syringe, and then we have a blood bag. So then we just inject it through a wide bore needle into the bag. Once around 350 to 400 ml is there, then we give it for transfusion. So it takes some time. The problem is leaving the head end and coming to be here with a
So this is the hemofuse device we're talking about. Or this is the
No, this is the old method. It's called the soup ladle technique.
Hemofuse we haven't used. So we don't know, but we have seen that.
Yes. So I mean, really exciting. So what are the next stages, do you think?
To get it through regulatory approval in one country, and then we need an industrial partner who is willing to sell it, to invest money into marketing. And then we need to speak to people who would use it to create awareness of such a device, and then maybe give them a few free samples, and then publish the results. So there's also scope for a lot of research, because this technique has been used for a very long time in mission hospitals and remote rural hospitals, but nobody's really done a lot of research on it. So there are questions on the cellular and chemical characteristics of blood in a peritoneal cavity. and whether various factors have been activated. So those tests can be done. We need to do more research to publish those type of studies.
I can't wait to see how this story progresses. I really can't. And I wish you all the very best of luck with it. And I hope you do find that industrial partner that you need to move this forwards. And best of luck with all the research endeavors too. I think it's a hugely exciting project and has a huge amount of potential. And congratulations and well done again on deserved winners of the Innovation Award here at the World Congress of Anaesthesia.
Yeah.
Thank you.
So that has been a great gift to us, because now this story of this device has found a much larger audience. And maybe there is someone who thinks I could help do the regulatory approval or get an industrial partner, or when it is ready, create awareness in their country for adoption of the technique. So we hope that all that falls into place in the future.
I absolutely hope so too. And if anyone listening to this at home is that person, then please do get in touch with us, and we're very happy to try and facilitate a connection. That would be fantastic. So yeah, thank you very much for joining us here on TopMed Talk. Thank you.
Thank you so much.
As always, you can hear this episode and all other episodes on topmedtalk.com or through your podcast choice. We're available on social media, as you know. If you do find us on social media, please hit like, hit subscribe. It really makes a difference to us at this end of the recordings. And lastly, a huge thank you to our sponsors for keeping us free and open access around the world, and that's BD and GE Healthcare. And thank you to the World Congress of Anaesthesiologists for hosting us here in Marrakesh. Thank you very much.
Thank you. Thanks.
TopMed Talk.
TopMed Talk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. Join clinicians from around the world at EBPOM World Congress 2026 between the 7th and the 9th of July at the British Library in London. 3 days of evidence-based perioperative medicine, global insights and expert debate, featuring speakers including Michael Marmot and Ken Rockwood. Go now to ebpom.org. That's ebpom.org.